This video we will talk about pancreatic cysts. Um, we will do the presentation, the symptoms, physical exam. That also includes the diagnostic modalities, the differential to treatment, and finally we will solve a U-World question regarding pancreatic cyst. So how does patients present with the pancreatic cyst? Pancreatic cysts presents with abdominal pain. Now, this may be a vague abdominal pain, and patients usually have a history of pancreatitis. Along with patients may have anorexia, indigestion, and nausea. You see, it's quite unusual, quite non-specific. Okay, so physical exam shows abdominal mass in the epigastric area, tender abdomen with sometimes fever if there is signs of infection, scleral icterus if there is obstruction of the biliary ducts, pleural effusions, peritoneal signs if the cyst ruptures. So, if symptoms are quite unusual, vague, then in that scenario you usually do an abdominal CT scan with a contrast. And when you do that, what you find is a well circumscribed fluid collection that is typically extrapancreatic with homogeneous fluid density with no internal septae. If that is so, this goes with a pancreatic cyst. Okay. Abdominal CT scan with contrast is a preferred diagnostic test. However, the most sensitive test is an MRI. Okay, because this allows you, with a better differentiation between a pseudocyst and other diagnoses like an aneurysm. However, CT scan, contrast, MRI, these are usually done. But endoscopic ultrasound is indicated in patients where the imaging findings or clinical settings is unclear or atypical. Okay, so why do you do that? Endoscopic ultrasound. Okay, let's say you have a patient who comes with such symptoms, presenting with abdominal pain, with a history of pancreatitis, and so on. You do a CT scan, okay, and you find out a well circumscribed fluid collection with the size and so on. Now, the next step would actually be to do an endoscopic ultrasound, okay? In this, what you're doing is you want to do aspiration of the cystic fluid as well, because you want to know what exactly the fluid is. You want to analyze the fluid, okay? So you do the endoscopic ultrasound, okay? You aspirate the fluid, okay? Why? Because you want to see if there is any suggestive feature of cystic neoplasm, okay? Although the CT scan actually tells you that there's no internal septae, whatever, but you want to do certainly analyze the cystic fluid, okay? So this actually helps you allow for treatment plan, okay? So when you do the cystic fluid analysis, you want to look for CEA 125 antigen, okay? You want to look for fluid viscosity and amylase. Generally, in any non-neoplastic fluid, the CEA will be low, the fluid viscosity will be low, but amylase will be high, okay? So if the amylase is high, this, can further complicate to pseudoaneurysms or in fact GI hemorrhage, okay? So always the initial test would be a CT scan with contrast, okay? However, the most sensitive one is MRI, okay? That is being asked in the question. The most sensitive, you would pick MRI, but most preferred and the first step would always be an CT scan with abdomen with contrast. Next would be an endoscopic ultrasound with aspiration. Okay, you have aspired the fluid and want to analyze the cystic fluid. Okay, next is this. Why do you aspirate the fluid? Because you want to differentiate that from a cystic neoplasm. MRI can often differentiate between pseudocyst and cystic neoplasm. If the diagnosis is still uncertain, ultrasound with fine needle aspiration of the fluid can be evaluated. And here again, you want to look for CAA 125, fluid viscosity, and amylase level. In neoplastic cystic neoplasm, the low amylase will be low. However, the CEA level and fluid viscosity will be high. Then, moving on to the treatment modalities. First up, you will always observe with follow-up imaging every 3 to 6 weeks. This is important. You always want to follow up your patient and observe for every 3 to 6 weeks. And supportive care includes nasogastric feeding or if needed for pain relief, because you don't want the pancreas to work when it is sick. Okay, then proton pump inhibitors, octreotide again to rest the pancreas, to reduce pancreatic secretion. Second line is the drainage of the pseudocysts. Okay, if indicated in patients who are symptomatic. Okay, if the cyst is enlarging quickly, or if there is any complications like infection. Okay, so what do you do then? You do an endoscopic drainage, which is preferred method of drainage. There are some complications like any other interventional procedures, which is bleeding, perforation, or secondary infection. Preferred one is endoscopic drainage, but percutaneous catheter drainage is always associated with more risk, high mortality, morbidities, longer hospital stay, and therefore endoscopic drainage is always preferred. Third line treatment is surgery, which is indicated in patients with infected pancreatic necrosis and symptomatic sterile necrosis. What are the complications of a pancreatic cyst? It may rupture, resulting in peritonitis, resulting in bleeding, hemorrhage. Okay, GI obstruction or a pseudocyst rupture. Okay, so these are the complications of a pancreatic cyst. Now let's solve a question from UWorld. So we have a 62-year-old female. She's being evaluated for vague epigastric discomfort, like exactly that we have discussed earlier, which she has had for past 2 months. She denies nausea, vomiting, diarrhea, flank pain, urinary symptoms, but she says she might have lost 2 to 3 pounds during this time. Now, I would just skip all this and mention some important points here, which is the CT scan. Okay, so some labs were done and the CT scan was done. You see the lipase is normal and near normal. Alkaline phosphatase, not very significant. CT scan, however, shows a loculated cystic lesion in the head of the pancreas with some wall calcification. So what is the best next step in the management of this patient? Yes, you would do an endoscopic ultrasound and aspiration. Okay, so cystic lesions in the pancreas are usually found incidentally on abdominal imaging and are classified as pseudocysts, non-neoplastic, or neoplastic, because these cysts can be cancer. Okay, therefore you need to do an endoscopic ultrasound. Okay, with a needle biopsy for aspiration. Okay, so ultrasound is most effective for biopsying lymph nodes and lesions in pancreas. Okay, this is why endoscopic ultrasound with aspiration is the best next step to evaluate a pancreatic cyst to differentiate malignancy from non-malignant cause. So when you're aspirating the fluid from the cystic lesion, you want to rule out any cancer. Okay, so this is all from the and I want to emphasize on this point as well. The option D here, pancreatic cyst, neoplasms account for nearly 50% of pancreatic cysts and can be asymptomatic. Further analysis with biopsy is required to identify malignant potential. Serial CT scans in 3 to 6 months are used to monitor benign lesions. First, we want to know if this is a malignant lesion or not, because of this high prevalence of pancreatic cancers. So you do analysis of the fluid. using an endoscopic ultrasound. So this is all. Thank you so much. Do subscribe my channel. Thank you very much.